This conference will now be recorded.
All right, David, you should be able to share your screen now.
Don't want entire screen here. Let's see. So allocations. Now we got it. Okay.
Good.
So
We're good.
here is a 26-year-old with this radiograph in 2017. And this is the same person 3 years later. This is 2020. And now there is a blob here, which on lateral view is way anterior up here. And it's got a very smooth border against the lung. So maybe it's outside the lung pushing in.
David, can you zoom in so we can look for incomplete border sign before going on? See if we can pleura, extra pleura, pulmonary. Yeah, it might have an incomplete border sign on its superior portion, perhaps. So that would speak, if I'm correct, and if it's correct, for pleural-based or extra pleural. And the adjacent sternum, I think, is okay. All right.
Okay. So here it is on CT. Definitely not normal. So, in terms of figuring out where this thing is, one of the signs of it's being outside the lung is that it pushes the lung in, and in doing so, it pushes vessels and bronchi away. And if I look at the vessels in this person, the vessels seem to be unperturbed by this thing. They don't seem to be pushed away. Looks to me as if this thing is actually in lung. So these vessels are heading into what it thinks is lung, but lung is now occupied by this. So I think the manifestations here suggest to me that this is a lung lesion. I don't know. What do you guys think?
It looks pretty lungy on that image.
we have we've waited so long for that adjective. Thank you, Jeff.
Well, if you prefer lungish,
It
but
Lung
still
like
fluid.
right
could
that
be.
image right there, right the image you have right there, David, with that really like narrow sliver of lung tank parenchyma medial, to me looks like it's in the lung rather than because if they were pleural, I'd expect it to be broader based. And I always
Yeah,
use the analogy of like a ball sitting on a rug versus a ball underneath a rug. And when you put a
yeah.
ball underneath a rug, it kind of creates like a more gentle slope, and that's more like just the ball sitting on top of the rug.
So I have the cat under the rug sign for that, and that's a good manifestation. Cat on the rug versus cat under the rug. So you know, I'll send you my picture of the cat under the rug sign. Okay, so this looks like a lung lesion to me. I don't know. What do you think, Howard?
Yeah, I certainly would accept that, but I think sometimes it can be hard to separate out pleural from
Hmm.
lung, something arising from a pleural membrane. But it doesn't have typical features of a chest wall lesion. In fact, the extrapleural fat just between it and the costal cartilage appears at least partly unperturbed.
Hmm. Yeah. It does have a very sharp posterior margin, though. Most lung lesions don't have such a well-defined margin against more normal parenchyma. Okay, long story short, this is a solitary fibrous tumor of the pleura. Now, I've seen a couple of cases where they grow into lung. So rather than growing outward, they just choose, I guess, less resistance and go into lung. So this has a very sharp margin. So I'm not sure it's really infiltrating lung, but it's definitely pushing into lung. So it is a solitary fibrous tumor. It was resected back then. It was, a benign lesion. There was no evidence of malignancy. So I think, as this discussion confirms, it's really can be very hard to tell whether something originates in pleura, chest wall, or lungs sometimes. And you can have conflicting findings that support one of the other locations. Um, It doesn't always work out. So humility, very useful in the practice of radiology.
Oh,
We show
yeah.
another case. This person has on the scout view a big pleural effusion, and then some maybe consolidation down here, or maybe all just effusion behind the lung. On CT, big pleural effusion, and then big pleural mass, very inhomogeneous. So, and I think this may be calcium in a vessel going to this thing. Just looking the way this tracks, I'm just wondering if that is a blood vessel that's calcified heading into this thing. So this also turns out to be a solitary fibrous tumor. And I need to look up the pathology on this one to make sure that it's benign. I was told that it was benign, but I need to check that myself. But generally, when you see this degree of inhomogeneity and you see accompanying pleural effusion, it's more likely, those are findings that make it more likely that this is the malignant end of solitary fibrous tumor. And I'm not sure, I think this is going to be resected, so we should have a complete specimen. And if there's any, if there was inconclusive on biopsy, we will have enough of a specimen to know for sure whether it was benign or malignant. So here's a very large solitary fibrous tumor. And these arise, they're supposed to arise in the visceral pleura. And they often, one of the favorite locations is the bottom of a lower lobe. So they often hang down from the bottom of the lower lobe. And I think this one qualifies as coming off the bottom of the right lower lobe, which I think we see better in the sagittal projection. Here's lower lobe through here, and then this thing is jutting backward into the pleural space. And because these things grow slowly, they can get to be very large. Okay, so two cases of solitary fibrous tumor. We have the pequeño on one side, and then we have the grande on the second case.
Another lesion to think of in general for something that looks like this and is large is IMH, inflammatory myofibroblastic tumor, a form of pseudotumor, but they may look just like this as well.
Have you seen those arise from the pleura, or are those?
No, typically in the lung.
Got it.
Yeah, but when it's large, it's hard to tell, right?
Yeah. Okay, guys.
All right. Thanks, David. Howard, do you have cases?
I have one.
All right.
This is a strange case for sure, and I really have a dearth of information. So this is a 21-year-old. The CT on the left is from 2022 and 2023 on the right, about a year apart. And I really couldn't find out what the patient's physicians were thinking of in 2022. So let's have a look at these opacities. It's very extensive. So these are subsegmental sized, of course, very ill-defined, not spherical, irregularly shaped opacities involving extensive portions of the lungs. And as I scroll through that again, I have no idea what anyone was thinking at the time. As best I can tell, they may have made some kind of clinical diagnosis, and the patient either was just followed up clinically or not followed up at all. I have no idea what happened. Let's go to the mediastinum and see if there's lymph node enlargement. Yeah, there may probably some here adjacent to the esophagus, subcarinal. Hard to know if this is abnormal tissue at that time as well, but there is abnormal tissue here, I think. But you will see that there is extensive progression. So again, about 1 year later, now we have very extensive disease. Pulmonary, multifocal, multilobar again. And then I'll switch over to the mediastinal window, and we'll see there's a lot of mediastinal pathology. Tissue in the mediastinum in multiple locations, very likely lymph node involvement, but very extensive. And as we go down, here it's really hard to separate the abnormal tissue from possibly some pericardial fluid or pericardial involvement by the process. Let's take a look at these opacities some more. So scrolling through them, besides being very extensive, of course, let's look at something like this one. And we can see there's some patent airways within. And in addition to patent bronchi traversing it, there are vessels, quite a few that traverse this process as well, particularly with respect to that one. So we can see that same phenomenon in other places where there are patent airways and patent vessels within these opacities. So progressive pulmonary, oh, here's a nice example of that. So there's one thing that I think of particularly for this kind of condition when we see patent airways and patent vessels. But David and Jeff, in general terms, what kind of things do you think of when we see these morphologic features? Okay, so it's a young person, and we have very extensive nodal disease and pulmonary disease. And
Well, lymphoma comes to thought, first thought, especially with
Yeah.
that discrete lesion with everything passing through it.
Yeah.
Yeah,
Lymphoma.
exactly. Yeah, some kind of lymphoproliferative or lymphoplasmacytic proliferative disorder. So one thinks of lymphomas in general. I've never seen IgG4 related sclerosing disease this extensive, but I think that's a very reasonable consideration, certainly for the pulmonary disease. Maybe not so much for the mediastinal tissue, but I think that's a reasonable thought.
And so is Erdheim-Chester.
Erdheim-Chester, let's have a look. For big masses like this, we don't really have
It is.
septal kind of disease, but these are big masses though for that, right?
Yeah, I've seen a lot of stuff hugging the pleura, in pleura and beyond, and also coating the mediastinum like this.
Okay.
One of the early cases we had where we just were beginning to recognize that condition was thought to be mesothelioma even because it was all of this peripheral stuff. So an adenocarcinoma, I think, is another consideration.
Now it's a young person, so, and clearly it's progressive, but clearly the patient isn't severely ill as far as we know.
Mm-hmm.
So it's
Any reason they could have like multicentric Castleman's disease, like HIV or something?
Multicentric Castleman's. Yeah, that's a thought. There's a very unusual condition that can produce pulmonary opacities like this sometimes, and that's the entity of epithelioid hemangioendothelioma in a young female. But I don't recall that it produces a lot of nodal disease. But if you get multifocal, multilobar opacities, and the patient's not particularly ill and slowly progressive, that's an entity to think about. So clearly we're kind of stuck. But I really like the thought, and that's the first thing that came to my mind too, some form of lymphoproliferative disorder.
So I don't know whether you'd see blobs like this with lymphangiomatosis, not lymphangioliomyomatosis, but proliferation of lymphatic channels. That could give you a lot of this mediastinal stuff. And but I wouldn't expect to see blobs.
Yeah, so I have a case of lymphangiomatosis, but there's a lot of like cystic spaces in the mediastinum, and then lymphangiectasia in the lungs where you just get sort of diffuse, distorted interlobular septa. This, I don't know, I still like lymphoproliferative for this.
Yeah, we don't have lots of septal lines or findings of interstitial edema to suggest a lymphatic disorder that impairs clearance of lung water per se. Yeah, just a very hard case. Huh? Clearly needs to be biopsied now, which of course it was. So, yes, indeed, this is a difficult diagnosis, but you can see there were two biopsies. First tissue was obtained by EBIS, and then subsequently by mediastinoscopy. And very abnormal cells. Now, this is lymph node station 7, and they did a very extensive workup because the diagnosis wasn't easy or clear, but ultimately based on observations about cell surface receptors, abnormal lymphoid cells, ultimately this is thought to be some not easy to classify B cell lymphoma. They looked for EBV, but that's not present. But they did demonstrate B cell clonality by PCR with some monoclonal rearrangement, so that goes along with that. This is the mediastinal tissue. Same thing here. And you can see they did a mega workup. Undoubtedly, like super expensive when you do so many of these tests, actually. But this was a difficult diagnosis. And there's a comment somewhere over here that refers to difficult to diagnose lymphoma. Yep. Strange case, 21-year-old
Wow.
with very
And
odd.
Howard, what was the time frame between the two scans or the between the
1
when the
year.
patient? Okay.
1 year. 11 months.
Very neat.
Says the morphologic and immunophenotypic do not neatly fit into a diagnostic criteria for any particular kind of lymphoma. And just a big discussion, but ultimately they settled on as you can see there, a form of B-cell lymphoma. So I'm sure they're going to treat her for that. Very extensive disease. Yeah, hard case, but yeah, good
Very
points
nice.
about the features that go along with a lymphoproliferative disorder. 429, 323.
Wow.
Yeah,
Must be more of a low grade one to percolate that long.
yeah, yeah. All right, that's my case for this week, Jeff.
All right, thanks. All right, I've got 3. Let's see. So I'll start with this first one. So this was an occupational screen, and I think David will like this one. I mean, everyone will, but you can see that this, so it's a PA radiograph, no history provided other than the age. So this is a younger adult. And David, you probably remember on the old B reading syllabus, there was a case just like this of multiple tiny nodules. And the
Actually
reason
called
they have a
histo.
case like this,
Yeah.
yes, not to be scored as pneumoconiosis. So there's all these tiny nodules, but it's important to recognize that they're very conspicuous. And normally we wouldn't resolve them this well on a radiograph. And so these are all calcified is the presumption now. Um, the older syllabus was actually a hard copy film, so it was much easier to see calcium on the film. But we still talk about this in the B reading course that to recognize when you see diffuse calcified nodules, sometimes you can see that with silicosis, but these are randomly distributed. They're more basal predominant, so it's not a typical silicosis or coal workers pneumoconiosis case. So this is presumably this is someone from the Midwest Presumably this is old disseminated histoplasmosis and not pneumoconiosis. If there was any question, you could always score it and then comment on it. But they used to have this as a pitfall case on the B reading exam, so it was kind of fun to come across one.
So
Good.
All right.
the other thing with those small calcifications like that we used to utter in the old days was varicella. So varicella was a cause of small lung
Mhm.
calcifications like this too. So when I saw the B reading example, they called it histo. I was going to say this could be varicella. They didn't even mention that possibility.
Yeah, it's funny. We don't really ever see that. The one case I have seen, the nodules were even smaller and more diffuse. Looks more like a miliary TB, but
Hmm.
yeah, that is very true. I guess we just don't see a lot of disseminated varicella anymore anyway, because vaccines and such. Okay, this is just another nice case, and this was not an occupational screen, but it's on the same flavor of cases. So it's a beautiful radiograph of a person who has really nice pleural plaque. You can see we see it in profile here along the diaphragm, along the right costal pleura, but also this huge area of calcification along the mediastinum, along the left heart border, left hemidiaphragm and here. And then I'll blow it up. There's also some face-on plaques right here. You can see an en face plaque. There's probably one here. Look on the other side. There's definitely a plaque here. And the ones they're easier to see when they're calcified because sometimes they have more of a stippled appearance. The other thing on this radiograph is the right costophrenic sulcus here is, although there's a little separation, would not qualify for diffuse pleural thickening. So it used to be there was one of the standards had a sulcus that was obliterated, and that was the standard. They now have on the brand new standards, they have actually one specifically for that. But usually it's about up to about there. If we look on the other side, this angle is obliterated. So this was scoreable here, and you can see there is some separation. So this qualifies for diffuse pleural thickening. Now, because this was not an occupational case, this was a clinical case, you can see we have a CT scan, and you can see really nice plaque. These are big, quite exuberant plaques. But we also have diffuse pleural thickening. Let me see if I can get there we go, make my image a little bigger here. You can see that while we have discrete plaque, we also have this larger area of diffuse pleural thickening on both sides. So it's a mixed pattern, but technically the right would not qualify in a B read for diffuse pleural thickening, despite the fact that the CT clearly shows it. So the teaching for the exam and the classification system is you cannot have diffuse pleural thickening without loss of the sulcus. But the CT, of course, shows the truth, and that is not the case in this patient. But just quite exuberant asbestos-related pleural disease. Now, if we look at the parenchyma, this is always where it gets a little tricky. Are we going to diagnose asbestosis of fibrosis? And you can see there are some subpleural linear opacities, but one of the things I always caution my trainees and when I'm talking to the pulmonologists about these patients is you want to make sure you look away from the plaques. Because sometimes you can get a little bit of adherent lung. The British describe this as hairy plaques. These aren't particularly hairy plaques. So I like to see fibrosis away from any pleural disease, preferably non-dependent. And if we look in the non-dependent lung here, we really don't see a lot. There's some bands of atelectasis. There's probably some very early fibrosis. There's definitely volume loss in the lower lobes here as well, but not a real exuberant case of fibrosis, predominantly pleural asbestos-related pleural abnormalities there. Just a little review of those. And then my last case is kind of cool, and I'll be curious what you all think. So if I don't give you any history, and I showed you this image right here, what would your diagnosis be?
It's got some tissue in, it's got some fat in, and it's got some calcifications
Yes.
within. So soft tissue, fat, and little dystrophic calcium.
And it's a female patient.
So,
So
um,
if this were on an exam or a quiz,
I think it would be germ cell tumor versus lipoma.
Okay, right.
Or
Yeah,
you're
it's got
talking about
tissue in
cystic
it.
teratoma? You mean a cystic
Yeah,
teratoma lesion? Yeah.
right. It's got fat, it's got
Yes.
calcium.
Yes. Yes.
There's a
Yes.
non-contrast that shows that is indeed fat. I mean calcium, and there's soft tissue in there. So and it's off midline. It's in the prevascular space, so it's good for teratoma. You know, you could have a lipoma that infarcted or bled or something. The problem is she's 67, which is kind of the wrong age for that tumor. Um, so I was thinking, wow, this is a weird looking germ cell tumor, but that's what I still thought that's what it was going to be. Either way, it needed to come out. So they resected it, and here are the specimens
Thymo,
from it.
not likely to be a thymolipoma because
No,
that's
not with that much
no,
fat
I
in it.
don't think so.
But see, we can see the mass here, and there's a lot of fat on it. Let's see if I can get a different image there, but that's just it showing in there. So the path came back, and it was really confusing. As an epithelioid hemangioendothelioma, which you were
Ooh,
talking about earlier,
ooh.
which it didn't sit right with me. I was like, that can't be. And I think of those as big solid masses, or sometimes they're multicentric in the lung or in the liver. But then when I pulled up the path report and actually combed through the whole thing, because it took them a while to get the whole report out, it's arising in a myelolipoma, which I've never seen a myelolipoma outside of the adrenal gland. So, yeah, they sent this case to our vascular tumor board because there was a positive margin. You can see right here on the brachiocephalic vein, it was up against it, but it is otherwise well circumscribed. But I mean, it looks all the world like a teratoma, just in a female patient, which are usually just benign. They remove them, but um, an epithelioid hemangioendothelioma arising in a myelolipoma. So that explains the fat. Um, the calcium, I guess, goes along with that, but I have no good explanation for this. But I mean, we've shown cases in the lungs, and I've seen them in the liver, but that's it. But
Um,
apparently they did include a case report of one of these tumors arising in a myelolipoma. So it may have something to do with the bone marrow elements in the tumor that just happened to give rise to a neoplasm.
Strange. Myelolipomas can occur in funny places like the pelvis and places like that, in front of the
Okay.
sacrum. But
Oh, I've never seen it. Okay.
that combination, and there's some syndromic entity that you can get myelolipomas, but an epithelioid hemangioendothelioma, rare thing, arising within a rare thing. Gosh, I
In a
don't
rare
know.
space.
I don't know.
But there's a case report, so it's not like it's
Oh,
the first one.
oh, the combination. Oh, I don't know what to make of
So
that.
anyway, it was just a
Gee,
cool one. I doubt any of you would have seen one because you probably would have shown it already, but that's good to know the myelolipomas can occur other places because I've only seen them in the adrenal glands, and that's
yeah,
all
they
I've ever heard
can
of them.
occur
And
in
I've never
funny
seen
places.
one of these other weird tumors outside of the lung or the liver. So, all right,
Gee,
well, oddball case of the week. All right, well, I think
different.
that is everybody. So we'll end here. Thanks for the great cases and discussion. I will talk to you all next week.
Thanks, everyone.
All right. Cheers.
Bye.
Thank you. Bye
Bye-bye.
bye.